Symptoms of GI health issues can range from annoying to causing discomfort. We're talking nausea, burping, bloating, frequent heartburn, and more. In this episode of Being Well, I'll sit down with Carle's Alicia Sledge to talk about ways to focus in on your digestive health and get it back in check.
When Sarah Bush Lincoln opened in 1977, it was with the promise to serve the community's healthcare needs. It has grown into a 2-hospital system with nearly 60 clinics that provide trusted, compassionate care.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
Carle is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carle, with Health Alliance, is always at the forefront to help you thrive.
Thank you for joining us for another episode of Being Well. I'm your host, Lacey Spence, and today we are covering a topic that we covered a little bit earlier in the season, but we thought it was so important we should talk about it twice. We are talking about gut health, and to help us further this discussion, we are welcoming in from Carle. We've got nurse practitioner Alicia Sledge here with us. Welcome to Being Well.
Hi, thank you. Thank you for having me.
Of course. So before we dive into this topic, can you give us a little bit of background? How did you end up in medicine?
So I originally, whenever I had my daughter, I actually had a phenomenal nurse. She was great. It made me really wanted to get into nursing. Yeah. So when I went in, I had intentions of becoming a midwife, but after doing my rotations, I realized that that was not for me. I became a nurse on a med-surg floor, and from there transferred to digestive health, and that has been my home since 2010.
There you go. Yeah, we're talking about midwifery this season as well. Very interesting field, but definitely takes a special person to do it.
Yes, it does.
A special person to also be doing what you're doing. So as we talk about GI health, I think maybe an okay place to start would be when it comes to colonoscopies. I think people maybe kind of psych themselves out about it.
They do.
The prep, the being put under. So when it comes to colonoscopy, what are you looking for?
So whenever we do the colonoscopy itself, we're looking for any irritation. So we're looking for any redness, polyps, any ulcerations. A lot of people, whenever they wake up after the colonoscopy, they do seem to be alarmed that they've had biopsies taken. So one of the things that we really want to let people know is it's common. It's common, biopsies are painless, it's pretty routine.
Okay, and so with that, you're taking a sample of something that maybe looked a little interesting or worrisome?
Yeah, so polyps actually look almost like skin tags.
Okay.
Yeah, so anytime we see those, we remove them.
And what are the polyps doing? Like, are they obstructing flow or?
No, so not always. I mean,
Okay.
unless they're quite large, which are concerning, but most of the time they're very small. But each polyp carries kind of a different risk for progressing into colon cancer. Depending on the number of polyps and the type of polyp, that will determine when you're due for a repeat colonoscopy.
Gotcha. So what if I have a history of colon cancer in my family? Does that change when I should be getting a first colonoscopy or?
Absolutely. So what we typically do is age of onset in a first degree relative. So first degree is of course your parents or siblings, or child. Any of those diagnosed with colon cancer, you look at the age of diagnosis and rewind 10 years. So if your family member was diagnosed at 45, you need to get screened at 35.
Okay. If I have no family history, then what's that first age?
Well, no family history and no symptoms. So no symptoms is important. If you're able to complete a Cologuard, then we actually order that test. It's actually shipped to your home. It's a stool sample, so you can actually complete that in the privacy of your home and mail it back in.
And at what age should I be looking into this kind of?
So now all screenings actually start at 45. There's actually some evidence out there to suggest that we're going to start screening earlier, possibly at 40 very soon.
Oh, gotcha. So definitely keep an eye out for that.
Absolutely.
Moving on to GERD, G-E-R-D. What's it stand for and what is it?
So gastroesophageal reflux disease, that encompasses things like heartburn, regurgitation. Most people have that typical pain in their chest, but some women actually have atypical symptoms. They don't often experience that. Sometimes it could be trouble swallowing or sometimes a little less frequent episodes of heartburn in women.
Mm-hmm. So how common is GERD?
Actually, it's estimated that over 20% of the population has GERD.
Wow, that's a lot.
It is.
Are there certain risk factors for that, or is it diet related? What causes it?
A lot of times it's diet related, but sometimes it could be a medication side effect. Sometimes meds increase your heartburn. Obesity is a big one. Your diet, if you eat a lot of tomato-based foods, it's going to definitely increase.
And who should be seen for GERD?
Anyone with chronic GERD, you've had it for a long time, been on a PPI medication for a long time, we want to see you.
And so this is more than just your routine, I have heartburn every now and again.
Absolutely, yes.
What would you consider chronic?
If you've had it for years, several years, and you've been on the medication, some individuals are actually on medications, but they still have breakthrough heartburn symptoms, we want to see you. And then there's alarm symptoms. So if you're having food stick in your esophagus or you're having any pain when you're swallowing, we want you to come in.
Ooh, how would I know if I have food sticking?
Well, whenever you swallow, you typically feel food stick. Most of the time people feel it here. So as it passes, it can get lodged.
Goodness, okay, so definitely a lot to be watching out for here. Earlier in the season, we did talk about Barrett's esophagus, but for folks who maybe missed the episode, can you kind of explain to people, what is that?
So any individual who's had chronic reflux for a number of years, average person is a white male around the age of 50. Typically it is a change in the lining of the lower esophagus, and so anytime you have Barrett's esophagus, we want to screen you. It is a precancerous condition from damage done from chronic reflux.
Gotcha. We've got a lot of things to cover here. If I want to have a colonoscopy or EGD, but I fear anesthesia.
Yeah, so that is one good thing about Carle. Carle actually offers no sedation.
Okay.
So if you have that fear, or perhaps you're just curious and you want to watch on the screen and you want to see what's going on, you have that opportunity.
Okay, well, hey, I mean, different strokes for different folks.
Right.
There's me who's like, I prefer to be super knocked out, but that's okay. There is a lot of very cool science there that I'm sure people do appreciate. Moving on to fatty liver disease. What is that?
So fatty liver disease is simply that it is an accumulation of fat around the liver. People who typically have fatty liver are those from the Midwest, because we are on that Midwestern diet, right? So we eat things like red meat, potatoes, and corn, and it's just not healthy for our liver. So most of us do have some degree of fatty liver. What we really want to get out to the community, though, is the fact that fatty liver can actually progress and lead to liver cirrhosis.
Okay, so let's talk about that a little bit.
Yeah.
So if I'm developing liver cirrhosis, how does that kind of present? What am I watching out for? Because I feel like fatty liver isn't something that, I'm going to be able to look into a mirror and even notice that I have in the first place.
So most of the time what we see is individuals who are referred to us with these mild elevations in their liver enzymes, or perhaps they have fatty liver that was accidentally seen on an ultrasound. That's where we see it the most. There's not really any symptoms of liver disease or liver cirrhosis until you're at a decompensated state. And so we really want to catch this early. So if you have the risk factors, you've had an ultrasound, what we really encourage is we are going to try to treat you as early as possible. So if you've had that ultrasound in the past, any abdominal imaging, you have fatty liver, we want you to come and see us.
When do you typically catch it? Like, I always think ultrasound is like, I know it's not just pregnancy, but like, do you catch it in pregnant women more, or?
Sometimes with fatty liver, patients can develop a mild abdominal ache in that right upper region of their abdomen. So sometimes they have those kind of issues. What we really look for in screening, if you have a history of diabetes, a family history of diabetes, elevated cholesterol, blood pressure, or if you're carrying your weight in your abdomen, you likely have fatty liver.
Okay. So as you're talking about scanning and testing for this, I have in my notes a FibroScan.
Yeah.
Is that the kind of test you're talking about, or is that something different?
No, so a FibroScan, unfortunately, I do see patients in Mattoon, and I do have to have them drive to Urbana to have this test done. The test itself is very quick. I often tell patients it's going to take 5 minutes, but then I've had patients come back 3 minutes later and they're done. Very quick. You lay down on an exam table, and there is a wand with a small probe at the end, and it taps your liver 10 times, and that's it. Very quick, painless.
And I'm so sorry, what are you testing for?
So what we're looking for is the amount of fat on the liver. Fat is scored as mild, moderate to severe. It's able to tell us that measure. But more importantly, it's able to tell us the amount of scarring. Scarring is scored 0 to 4. 4 is estimated liver cirrhosis. So of course, everybody wants a 0. But if that test shows a 3 or a 4, we will recommend a liver biopsy.
Okay. So with that, you said it's very quick.
Very quick.
Do you ever have people who are, I guess, maybe nervous to get it or nervous of their results?
Absolutely. So we try to get the results as quick as possible to them. As far as the test itself, I tell them, especially if they're going to make that drive from like Coles County to Champaign, go find something fun to do. Preparation for it is fasting for 4 hours. So go shop, go eat, make it a fun day. Don't make it something, you know, traumatic. It's a very quick test with great results. So we do encourage everyone to get one done if they have fatty liver.
And so as you're talking about diet playing a factor in it, if I'm somebody who's maybe got a healthier diet and maybe not carrying weight around my midsection, can I still have fatty liver?
Absolutely. So we're actually seeing more and more individuals who are of healthy weight who do have fatty liver, and a lot of that we attribute to diet.
Really? So do you have any more insight on that as far as what in the diet? If is there a way to eat for a better fatty liver?
Well, and so we typically recommend general GI. We recommend Mediterranean diet, and I feel that most people in the community sometimes when they say, well, it's very expensive to eat healthy, we actually looked up not very long ago, and it costs about $10 for a medium-sized meal from McDonald's. You can actually buy an 8-pack of chicken breasts, 2 heads of broccoli, and a 2-pound bag of rice for under $20. That's a meal for an entire week. So it's doable. You can do this. You can eat healthy on a budget.
Yeah. Well, and to save people a Google, if they're not familiar with the Mediterranean diet, what does that typically look like?
What we want to see with that is it's limiting your red meat. We want to see those lean proteins, chicken, fish, you know, none of the fried food, processed food, high fats, high sodium. We want vegetables and fruit. There's not a lot of secret to it. Shop in the outside aisles, stay away from the inner aisles. The Mediterranean diet is healthy overall. It's very low sodium. It's good for most of your body systems, not just GI.
Yeah. Limiting the processed food, I'm sure helps as well.
Yes, absolutely. Absolutely.
Gotcha. So moving on to advanced liver disease, is that different than the liver cirrhosis?
So that is, advanced liver disease is liver cirrhosis, but once you have liver cirrhosis, there's 2, compensated and decompensated. If you're compensated, your body has done a great job of, you know, battling the fact that your liver is scarred, and so you kind of look at the liver like it's a filter. So it's clogged, but you don't have those symptoms, there's no signs, so your body's doing well. Our goal is to keep you at that compensated state and prevent you from decompensating.
And then the other type was the cirrhosis then?
Nope, the decompensated liver cirrhosis. That's where you'll see those signs and symptoms. So you'll typically see things like yellowing of the skin or eyes, dark urine that looks like Coca-Cola, bowel movements that are clay-colored, light-colored, abdominal fullness from fluid that accumulates, sometimes confusion, swelling in the legs, things like that.
And I know that we've been talking about diet a little bit, but I also feel like a lot of people associate liver health with alcohol consumption.
Right.
Can you speak to that at all?
The biggest thing that I see that we really want to push to the community is letting people know you do not have to be an alcoholic to have liver cirrhosis.
Okay.
Fatty liver itself progresses, and so oftentimes I have these sweet patients who come in and I have to give them the unfortunate news that they have liver cirrhosis, and they say, how did this happen to me? I've never drank alcohol, I've never done any drugs. And then they tell their church congregation or their friends and family, and they say, oh, I didn't know you had an alcohol problem. So that is a big one. We really want to push that. You do not have to drink alcohol.
And as a side note as well, even if you are happening to consume this and you're having liver issues, please don't be afraid to reach out because of that.
Absolutely, absolutely. It's kind of the same as smoking. Individuals who smoke cigarettes daily, that doesn't mean you're going to get lung cancer. If you drink alcohol daily, that doesn't mean you're going to have liver cirrhosis.
Moving on, we've got NASH and MASH.
Yes.
What are those?
So NASH is non-alcoholic steatohepatitis. That when we say the word hepatitis, we're not meaning chronic hepatitis like Hep B, Hep C. We're meaning inflammation of the liver. That's it. So the steato portion of that word just means fat. So fatty liver that has caused inflammation. That is the more progressive form. That is the type that we often see progress and lead to liver cirrhosis. We now call it MASH for metabolic associated dysfunction steatohepatitis.
And so how do we treat MASH?
It is very simple, unfortunately. There are medications in the works that we're trying to get FDA approval for, but as of right now, we don't have any medications to treat it. It's lifestyle. It's the Mediterranean diet. We want to see exercise. Exercising 5 days a week, 30 minutes a day, no 2 days off in a row. We want to see that weight loss.
And does that have to be intense exercise? Can it just be as simple as walking?
Not at all. Yep, simple as walking, just getting moving, doing things. There was actually a study done at a point in time that had several patients that were diagnosed with NASH, and they biopsied them at the beginning of diagnosis and biopsied them 1 year later. In those patients that had lost 5% of their overall body weight, we actually saw a significant reduction in fatty liver, but no change in scarring. In those patients that lost 10%, there was a big reduction in not only the fat, but also the scarring. So what we recommend, we want to see that 10%, not quick, usually within the first 6 months, and then maybe another 10% 6 months later.
With that Mediterranean diet, is that kind of teaming it up with maybe a caloric deficit or?
Maybe, yes, absolutely. So we do want to see those calories go down. I often challenge people to go and write out their normal diet, what they typically spend, what they typically eat, and then bring that in. We can always take a look at it and see where they need to make those changes.
And so when you come across patients, have they typically seen their primary care doctor first?
They do. The issue sometimes, though, is that they've been told years ago that they had fatty liver, but they just didn't think anything of it. They thought this is very common, and so no real follow-up is done. But when they were first told, often we say, oh, you gotta work on diet and exercise, there's no treatment. We are seeing these diagnoses of non-alcoholic cirrhosis patients increasing. So it's very important right now to really get the word out that fatty liver can progress and lead to cirrhosis.
So in your time in this field, this lane, are there any cases that come to mind where you've seen some maybe radical lifestyle changes that had a lasting impact? Can you talk about it?
Well, so some of these patients, what we tell them, anything before liver cirrhosis, you can reverse it. So, most of the time people say scarring can't change. That is not the case with the liver. It's actually able to regenerate cells. So let's say you're at a stage 3 and you work hard and you follow the diet, and we shouldn't really say it's a diet anymore, right? It's just healthy eating and daily exercise. Yeah. So if you're doing those things, we see that 10% weight loss, we can often re-scan you with a fibroscan, or sometimes re-biopsy, and we have seen a lot of patients get rid of that scarred tissue.
Very nice.
Yeah.
Is there ever an instance where part of my liver maybe needs to be removed? Can you?
Well, once you have liver cirrhosis, no. Unfortunately, we don't want you to have a liver biopsy or a liver transplant. What we want is to preserve what liver function you have. So by, if your liver cirrhosis was caused by alcohol, of course, stopping it is going to be important. If it's fatty liver, changing your diet and lifestyle is going to be important. So if we can get you to make those changes, that's where we want to see you at. But unfortunately, some patients will turn into decompensated liver cirrhosis, and the only treatment for that is a transplant.
Gotcha. I assume that's probably a very lengthy and strenuous process.
It is, and unfortunately a lot of patients, you have to be referred to an outside facility, so we're looking at IU in Indianapolis, Northwestern, or maybe Barnes. But we do have the luxury of having a physician from Northwestern that actually comes down the first week of most months and sees patients at Carle. So instead of driving all the way to Chicago to meet with them, you can get established at Carle, so only an hour away.
Gotcha. That would be very nice to save some time on the road for sure. In our last several minutes here, I have to ask, what do you most commonly have come through your doors?
We see a variety of everything. I do see a lot of liver patients, but we also see pancreas. So most people don't really realize that we do see pancreas patients, pancreatitis, pancreatic lesions, and then all forms of general GI. So any swallowing issues, colitis, anything like that we see.
Well, since we have a moment, are you able to talk about either of those conditions, whether it be pancreatitis or colitis or both?
So a lot of the colitis, it depends on what's causing it. So is this inflammatory bowel disease, which we actually have nurse practitioners that are specialized in inflammatory bowel disease like ulcerative colitis or Crohn's. So often when those referrals roll through, we make sure to set you up with them because that's how you're going to get the best care. Pancreas issues, there's a few of us other providers that are specialized in the pancreas, and we have a few wonderful physicians that are trained in the more advanced endoscopies, and that's who you're going to be established with is us. Typically, pancreatitis is caused by either chronic alcohol use or gallstones. Those are the two most common causes.
With gallstones, aren't those painful?
Not always.
Not always? Okay.
A lot of us have them, you just don't know it.
Oh.
Yeah.
How do you usually discover those? Is that
incidentally, unless one of them happens to fall out and becomes trapped in the bile duct. Then you typically have pain, symptoms. You may turn a little yellow or your eyes turn yellow, but most of the time, fever, chills, pain in that right upper quadrant, things like that.
And we've been talking an awful lot about ailments that are impacting adults. Do some of these conditions also impact children?
So we do see a lot of children with these issues. Carle actually has pediatric gastroenterologists too. So in my group, we see 18 and older, but in anyone under the age of 18, we get you established with pediatric GI.
Before we wrap up, is there anything about the topic or about what you do that I didn't ask about that you think is important for the viewers to know?
I think the main thing is if you have those risk factors or you're having symptoms, unexplained weight loss, change in bowel habits, any of the blood in the stool, come and get screened. Get your colonoscopies completed. If you don't have the risk factors, complete the Cologuard. If you have fatty liver, we want to screen you, see where you're at on that SCAR score. And if you've had untreated heartburn reflux for years, or you are treated and you're still having symptoms, we want to get you scoped.
And again, if I'm wanting to get screened or get the Cologuard, I'm supposed to go through you or my primary?
Both.
Both.
Absolutely.
Both can handle that.
Yep.
Gotcha. Some final thoughts as your time in this field. Is there any big changes that you've seen in how people are treated? Advancements maybe?
Well, as far as our patients go, we have seen some big changes, like even the colonoscopy prep. When I first got into this, patients were actually having to drink a gallon. And so now you're only having to put away 64 ounces, so it's a lot easier. We keep making improvements all the time. When we started, screening ages of colonoscopies was 50, now we're at 45. I won't be surprised at all when we reduce it much lower.
Do you think you could see it go even lower, like early 30s?
Probably.
Or is that due to the diet then, or more family history? Or?
Genetics play a strong role, and of course our environmental factors, so our diet, our lifestyle, things like that can play a role.
And of the conditions that we spoke about, what's maybe the most rare that you don't see quite as often?
Well, so there are other causes of liver cirrhosis. Aside from alcohol and fatty liver, we do see a variety of other possible causes. Without going into the long terminology of it, this could be due from too much iron, too much copper, protein deficiencies, and autoimmune causes where the body is either attacking the liver or the plumbing around the liver.
I didn't even know that too much iron was a thing. I wish I had that problem being on the more anemic side of things. But nurse practitioner Alicia Sledge, thank you so much for coming and filling us in on everything in the GI region. We sure appreciate it.
Thank you for having me.
Of course, and we want to thank our viewers for joining us for this episode of Being Well, and we hope to see you next time.
Carle is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carle, with Health Alliance, is always at the forefront to help you thrive.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
When Sarah Bush Lincoln opened in 1977, it was with the promise to serve the community's healthcare needs. It has grown into a 2-hospital system with nearly 60 clinics that provide trusted, compassionate care.